Good evening to one and all present here for the clinical presentation on diabetic foot ulcer case. I am Aditi, the IMA MSN General Secretary. It's a complete honor for me to welcome you to the event. I would like to welcome Dr. V.V. Chinivalar sir, President IMA KSB, Dr. Suriraju V sir, Honorable Secretary IMA KSB, Dr. Narayan Murthy C sir, Chairman Academic and Medical Education Subcommittee, Dr. Subrata Ma'am, Psychiatry Professor at Shivamogga and Member of Medical Education Committee. I would love to welcome the speaker of the day, Vedika Verma, a third-year MBBS student of ESIC College, Bengaluru, and the moderator of the event, Dr. Pawan Sir, Professor, Department of Surgery, SSMC Tumkur. I would also like to welcome Dr. Palakshayya Sir, Senior Professor, Orthopedics, BMCH Chitradurga, Dr. Geeta Ma'am, Senior Professor, OBG BMCH Chitradurga. Thank you. Let us start the event with the IMA prayer. The IMA prayer is, may everybody be happy, may everybody be healthy, may everybody be free from pain, may everybody be free from sorrow, may we be the healing cure beyond every greed and lure. Thank you. Now I would request Dr. Subrata Ma'am to do the flag salutation.
ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಸದಸ್ಯರಾದ ನಾವು ನಮ್ಮ ರಾಷ್ಟ್ರ ಧ್ವಜಕ್ಕೆ ವಂದನೆ ಸಲ್ಲಿಸಲು ಇಲ್ಲಿ ನಿಂತಿದ್ದೇವೆ. ಅದರ ಗೌರವ ಮತ್ತು ವೈಭವವೇ ನಮ್ಮ ಬೆಳಕು ಮತ್ತು ಶಕ್ತಿ ಮತ್ತು ಅದರ ಪಥವೇ ನಮ್ಮ ಪಥವು. ಈ ರಾಷ್ಟ್ರೀಯ ಸಂಸ್ಥೆಯ ಮಾನ್ಯತೆ ಪಡೆದ ಸದಸ್ಯರಾದ ನಾವು ನಮ್ಮ ಜವಾಬ್ದಾರಿಗಳನ್ನು ಅರಿಯುವ ಮೂಲಕ ಅದಕ್ಕೆ ನಮ್ಮ ನಿಷ್ಠೆಯನ್ನು ತೋರಿಸುವ ಪ್ರತಿಜ್ಞೆ ಮಾಡುತ್ತೇವೆ. ದೇಶ ಸಮೂಹಗಳ ನಡುವೆ ನಮ್ಮ ರಾಷ್ಟ್ರಧ್ವಜವು ಉನ್ನತ ಮಟ್ಟದಲ್ಲಿ ಹಾರಾಡುವ ಸಲುವಾಗಿ ನಮ್ಮ ಅಧಿಕಾರದಲ್ಲಿರುವ ಎಲ್ಲವನ್ನೂ ಅದಕ್ಕೆ ಸಮರ್ಪಿಸುವ ಪ್ರಮಾಣ ಮಾಡುತ್ತಿದ್ದೇವೆ. ಜೈ ಹಿಂದ್. IMA ಚಿರಾಯುವಾಗಲಿ.
Thank you, ma'am. Now I would request Dr. V.V. Chinivalar sir to say a few words.
Hello. ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. ಕೇಳ್ತಾ ಇದ್ದೀರಿ? Can you hear me? Hello?
Sir. Yes, sir.
Yes, sir.
Yes, sir. Yes, sir. ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. ಇಂದಿನ ಅಕಾಡೆಮಿಕ್ ಅಂಡ್ ಮೆಡಿಕಲ್ ಎಜುಕೇಶನ್ ಸಬ್ ಕಮಿಟಿಯ ಮುಖಾಂತರ ಹಮ್ಮಿಕೊಂಡಂತ ಈ ವೆಬಿನಾರ್ನಲ್ಲಿ ಅಂತ ಚೂಸ್ ಮಾಡಿದಂತ ಒಂದು ಟಾಪಿಕ್ ನಿಜವಾಗಿಯೂ ಇಟ್ಸ್ ಒಳ್ಳೆಯದು. ಡಯಾಬಿಟಿಕ್ ಫುಟ್ ಅಲ್ಸರ್ ಕೇಸ್ ಅಂತ ಪ್ರೆಸೆಂಟೇಷನ್. ಬಿಕಾಸ್ ಇನ್ ಡೇ ಟು ಡೇ ಲೈಫ್ ವಿ ಆರ್ ಸೀಯಿಂಗ್ ರೆಗ್ಯುಲರ್ಲಿ the diabetic foot ulcer cases. So how to treat this, how to deal with these cases has to be dealt nicely by the Professor Dr. Pawan Kumar. Is going to train the students as well as he will be enlightened more about this diabetic foot ulcer. So let us have a good session and all the best to the presenter, Vedika Verma. So all the best. They say third year MBBS students from Government Medical College, Bangalore, and moderator Dr. Pawan. So definitely he will enlighten about this diabetic foot ulcer, and it will be useful for all the students as well as the practitioners. Thank you.
Thank you so much, sir. Now I would request Dr. Suriraju sir to say a few words.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. ಮೊದಲನೇದಾಗಿ IMA ಅಕಾಡೆಮಿಕ್ ಅಂಡ್ ಮೆಡಿಕಲ್ ಎಜುಕೇಷನ್ ಕಮಿಟಿ ರೆಗ್ಯುಲರ್ ಆಗಿ ವೆಬಿನಾರ್ಸ್ನ ಕಂಡಕ್ಟ್ ಮಾಡ್ತಾ ಇದೆ. ಐ ವಾಂಟ್ ಟು ಕಂಗ್ರ್ಯಾಚುಲೇಟ್ ಡಾಕ್ಟರ್ ನಾರಾಯಣ್ ಮೂರ್ತಿ ಸಿ ಚೇರ್ಮನ್ who is taking special interest conducting regular webinars, and I appreciate students for coming forward and for the presentation of webinars. That's most important. So as sir was telling, Dr. V. Chinivalar told, diabetes is a silent killer disease. It is affecting each and everyone. Every family is indirectly, directly affected today, and it affects each and every part of the body. As today the topic, the diabetic foot ulcer, is very common. Most of the time we assume that, ulcers treatment. Suppose if the ulcer is not properly treated, it can lead to ischemia, leading to, necrosis, leading to some other problem. And it is very important to recognize at the early stage, control the diabetes, and treat the ulcer. Nowadays in Bangalore, food care clinics are available to diabetic food care clinics. So anyway, I want to congratulate Dr. Vedika Verma, third year MBBS student. I hope this webinar will be helpful for each and every student. Not only she's representing students from entire medical college of Karnataka, and hopefully this kind of presentation will help everyone. I congratulate Dr. Pavan sir. Definitely under his guidance, the topic will be covered and it will be helpful for each and every student. Thank you.
Thank you so much, Suriraju sir, for your wonderful words. Now I would request Dr. Subrata ma'am to introduce our speaker and the moderator for today.
Good evening, everyone. At the outset, on behalf of Academic Committee, IMA KSB, Dr. Narayan Murthy sir is not here because of some other travel, some meeting. So on behalf of the committee, I would like to thank Dr. Chiniwala sir and our secretary, honorary secretary, Dr. Suriraju sir, for giving us this opportunity to do these webinars. And whenever we try to do this, I think getting a very good professor who's a good teacher is very important for us. And in that way, we are lucky today to have Dr. Pavan BM here as moderator, as an examiner for the students. Dr. Pavan BM is a professor in surgery in SSMC Tumkur. He completed his MBBS from WIMS Bellary in 2003 and his MS surgery from JJMC Davangere in 2008. He has many articles, scientific articles in journals to his credit. And he has worked as treasurer from 2012 to 2016 and secretary from 2016 to 2018 for ASI Tumkur City Chapter. And more than all these things, I think the basic fact for us, very important, is that he's a very good teacher and he goes as examiners for students. So we are very honored to have you here, sir. We welcome you to this program. And getting a moderator is one thing, and getting a student to present is also a big thing, because students agreeing and presenting it in a public platform like this is difficult. And we have Vedika Verma, who is doing her third year MBBS from in BMCRI. So we welcome you too on behalf of IME KSP. Over to Aditi.
Thank you, ma'am. Now I would request Vedika to share her PowerPoint and start the presentation.
Am I audible? Hello?
Yes, Miss Radhika.
Yes.
Okay, I'll just share.
You can, yes. Aditi, you can keep sir's, Pavan sir's spotlight, make it.
Shall I start?
Yeah, Miss Vedika,
Yes, sir.
Pavan here.
Yes.
Okay, sir.
Yeah, I
So
don't
I'm-
want to interrupt till history taking. Once you complete the history taking, I want to
Yes, sir.
clarify a few things, okay? I don't want to interrupt till history taking. Till general physical examination, you can present. Afterwards, you give a pass. We'll discuss few
Okay.
things.
Okay, sir. So I'm presenting a case of an ulcer. So starting with the patient particular, a 65 years old female who is educated till 5th standard and housewife by occupation and is lower middle class by Kuppaswamy classification from Bengaluru, came to the OPD with the complaints of wound over the right foot since 20 days and complaints of right lower limb swelling up to knee since 4 days. History of presenting illness. Patient was apparently normal 20 days ago. Then she developed a bleb over the inner side of the right foot, which was sudden in onset. Next day, it was burst
Vedika.
open to form an ulcer. Yes, sir.
Sorry to interrupt. Please, can you go slow? The other students has to follow, no?
Oh, okay, sir. So shall I begin with the chief
No.
complaints?
You start with the step presenting list. We go slow. There are other students.
Okay.
Let them also follow and let them also understand.
Okay, sir.
Go slow. Okay, Miss Vedika, continue.
History of presenting illness. Patient was apparently normal 20 days ago. Then she developed a bleb over the inner side of the right foot, which was sudden in onset. Next day, it was burst open to form an ulcer, which was around 2 into 2 centimeter in size. And in span of 20 days, it gradually progressed to reach 5 into 5 centimeter. Ulcer was associated with scanty purulent discharge, which was foul smelling, no aggravating and relieving factors. Patient also complains of pain around the ulcer since 20 days, sudden in onset, which was burning type of pain, which aggravates on walking and relieves on lying down, and the pain is non-radiating. Patient also complains of right lower limb swelling since 4 days, which was sudden in onset. Initially, the swelling was noted around the foot, then in span of 4 days, it spreads towards the knee. The swelling was associated with dull aching pain. Swelling partially subsided in the morning and aggravated in the end of the day. She had no, so for the negative history, she had no complaints or history of fever, no history of altered sensation in the foot, and no history of claudication pain. Now coming to the past history. So the patient is a known case of diabetes mellitus since 5 years and is on regular medication. No history of previous such complaints, no history of hypertension, tuberculosis, asthma, or epilepsy, no history of previous hospitalization and surgeries. Personal history, the diet is mixed, sleep is adequate, ball and bladder are regular, appetite is good, and the patient seems to have no addictive habits. Drug history, since she's on regular diabetic medication, she takes vigabatrin and metformin tablets. Family history is not significant here. Yes, sir.
Finished, Miss Madhika?
Okay, physical examination. Okay.
Okay, you stop there. Okay.
Yes, sir.
Now, starting with the patient particular, you might be knowing about the importance of name. Okay.
Yes, sir.
So you might be knowing, we'll start from the basic thing. Name is to develop a good rapport with the patient. Is it not? What is
Yes,
the
sir.
importance of knowing the age?
Sir, age for like old age, the healing, if the patient is presenting with an ulcer, the healing would be delayed. So the age matters a lot.
The age is like, suppose a same case, ulcer. It is presented in a case of elderly male and an younger male. And you also think like in elderly male, if it is due to arterial ulcer, you may think of atherosclerosis. In younger
Yes.
age, may be due to Berger's disease. Same complaint, same clinical history. That is the thing. Suppose a female of aged about 45-year-old and the other female with age around 20-year-old. She presents with you with a lump in the breast. Then this is in general, not relevant to ulcer. This is in general. Okay. So in
Yes.
elderly female, you can think of carcinoma of the breast. In younger female, you can think of fibroadenoma. That's
Yes, sir.
that is one thing you can. So that is the importance of knowing it. Same symptom, same clinical history, but differs in age. Got it?
Yes, sir.
Next is the other gender, education, occupation, socio-economic status, and address. Move to next slide. So always mentioning the chief complaints, it should be on the chronological order. You got it now? What is chronological order?
Yes,
So
sir.
it
Yes,
should be
sir.
in the sequel. So here the patient is complaining. There is a comes with the history of wound over the right foot since 20 days, and history of swelling in the right lower limb till knee since 4 days. Yeah, it should be in the chronological order, means which started first and which started late.
Yes, sir.
Got it? Next. The history of presenting illness means you will be elaborating all the chief complaints in detail. Okay. Like
Yes,
means
sir.
initial patient has given history of ulcer over the right foot since 20 days. we will ask about the ulcer, how it started, mode of onset. Okay, what was the duration, how it progressed, what are the associated symptoms, what are the aggravating and relieving factors. And again, second complaint, history of swelling, how it started, means mode of onset, the progression, associated symptoms, aggravating factors and relieving factors. And lastly, you will ask about leading question to rule out few things, like what you asked, negative history of fever, claudication, pain, history of previous complaints, all those. Got it? So what was the onset, mode of onset of this bleb? Ms. Vedika? Ms. Vedika, am I audible?
Yes, sir.
Okay. So here the bleb was sudden in onset. Okay.
Yes, sir.
Sudden in onset, the next day it burst open to form a ulcer. So its mode of onset is, the mode of onset of the ulcer, it started with the bleb and the next day it burst open to form an ulcer. Initially, when the patient noticed the ulcer, it was about 2 by 2 centimeters.
Yes, sir.
Okay. The ulcer, the mode of onset is sudden in onset from a bleb. Okay. The patient doesn't know how the bleb started. Maybe due to trivial injury, very minimal injury. Maybe the bleb might have started. We don't. In a span of 20 days, it progressed to reach a present size of 5 by 5 centimeters.
Yes, sir.
Okay, that was the progression. Then you want to ask about associated symptoms. Usually, what will be the associated symptoms of the ulcer? There will be discharge. So, patient has given history of scanty, purulent discharge, which was whole smell.
Yes, sir.
Is it not? This is an important history. Why? It suggests the ulcer might be infected. Clinically, it could
Yes.
be spreading ulcer. Is it not?
Yes,
So,
sir.
depending on the types of discharges, we also think about suspect the ulcer could be healing ulcer, the ulcer could be
Yes, sir.
spreading ulcer, or it can be a callus ulcer. Clinical.
Yes, sir.
Now, here the patient has given history of antipurulent discharge, which was whole smelling. That
Whole
gives a
smelling.
hint that this could be a spreading ulcer. Okay. And you mentioned no aggravating and relieving factors of the discharge or ulcer. This is no aggravating and relieving factors of what? Discharge or ulcer.
Hello.
Okay. Am I audible?
Yes, sir. The voice was cut in between.
Am I audible, Ms. Vedika?
Yes, sir. Yes, sir.
Okay, okay. So this was no aggravating and relieving. I think it is you have written no aggravating and relieving factors of the discharge.
Yes, sir.
Okay. So the next complaint is it
Pain.
also complains of pain around the ulcer since 20 days, just sudden in onset, burning type of pain, aggravates on walking and relieves on lying down. Pain is non-radiating.
Non-radiating.
Okay. So if
Yes,
the
sir.
mode of onset of pain is
Sudden in onset.
sudden in onset, and you have to also depend about the character of the pain. And depending on the character of the pain, will also be knowing few things. Two characteristic pain from them, like in throbbing pain. So clinically, in throbbing pain in surgery, we say it is a classical thing in abscess. Okay, your burning type of pain or pricking sensation of pins and needles
Yes.
seen in peripheral neuritis, which is a sequel of diabetes mellitus. Okay, dull aching type, burning type, scalding type of pain. They suggest few probable diagnosis. Is it not? Here the patient is complaining of pain around the ulcer since 20 days.
Yes, sir.
Which was sudden in onset, burning type of pain, aggravated on walking and relieves on lying down, and pain was non-radiating.
Yes, sir.
Do you know the difference between radiating pain and referred pain?
Uh,
Yes, Vedika? Miss Vedika, am I audible?
hello, sir. Sir, am I audible?
Yeah, you're clearly audible. You can continue.
Wait, sir, wait. Sir, for the radiating pain, it starts. Sir, am I audible?
Yeah, clearly audible. You can
It's
continue.
going down all the time.
Yeah, you can continue.
Is my screen share visible?
No, Miss Vedika.
Okay, sir. Sir, just 1 minute. I don't know why my internet just
Okay.
went off. Yes, sir. So, sir, the radiating pain, it starts from one point and it radiates due to inflammation to the other part that is nearby. And for the referred pain, the pain is there on the one source and felt on the other side. It is generally because all the nerves are together in the spinal cord. So there is misinterpretation of the sensory signals in the spinal cord uh, detected by the brain. For example, if we take example of myocardial infarction, the pain is there in the heart but felt on the shoulder, in the left shoulder, left arm, and the jaw. Similarly, for gallstones and pancreatitis, it is all example of the referred pain. And for radiating pain, we can give examples of sciatic nerve injury. Yes, sir.
Yes, continue.
And what else I can tell? Yes, sir. Mechanism of action, examples, and types.
Okay, I'll give you a classical example in surgery. Because we are discussing the surgical case now. So I'll
Yes, sir.
tell you the referred pain. Usually referred pain means, so the pain doesn't remain at the original site where there is
Yes, sir.
pathology. Okay. In the initial stages of appendicitis, the visceral peritoneum usually insensitive to pain. So, but it is innervated by the dermatome T10. Okay. So initially the pain will be felt around the umbilicus. Okay, that is referred pain. The pathology is there in the appendix that is situated in the radial fossa, but the patient feels pain around the umbilicus, that is due to common dermatome T10. That is referred pain. The pain may not be felt at the original site, but it is referred somewhere.
Yes, sir.
Okay. So whereas in radiating pain, the pain also is present at the source and also it radiates to the other parts of the body. Okay.
Yes,
Like
sir.
what you said, shooting pain in sciatica. Continue. You know the difference between radiating pain and referred pain, na?
Yes, sir.
Yeah, continue.
So, patient also complains of
Right lower limb swelling that was in 4 days, which was sudden in onset. Initially, the swelling was noted around the foot. Then, in the span of 4 days, it spread towards the knee. The swelling was associated with dull aching pain. Swelling partially subsided in the morning and aggravated by the end of the day. Is it not?
Yes, sir.
Okay.
Yes, sir.
So, what do you think from this?
Sir, from the history of presenting it.
from the history of till this, like we might think like the inflammation has been spread from the site of origin to the other parts, right, till knee. Maybe due to cellulitis also, it's called as cellulitis, and it can be also due to any inflammatory edema. Okay.
Yes, sir.
Hmm.
Grade 3 edema is present since it is present till the knees. And since the patient complains of pain, so swelling caused due to inflammation or any kind of infection that can be there. Now, because there is scanty purulent discharge, so it means that it's a bacterial infection. For example, we see discharges in many types of ulcer. In TB, we see yellowish kind of discharge. Greenish discharge we see in the pseudomonas due to pseudocyanine.
Yeah,
And if
we'll
it
come to the
bleeds, then it's a
discharges later.
malignancy. So we rule out malignancy. Yes, sir.
Okay, continue. Don't worry.
Yes, sir. So scanty purulent discharge is one of the factors that leads us towards the chronicity and whether it's healing or not. Because purulent discharge we don't see generally in the healing ulcers. So it's mostly a chronic, non-healing ones. We can go to that side. And then false smelling shows there is some type of infection. Yes, sir.
So here the patient has come with both the ulcer and the pain. So what are the
Yes,
things
sir.
you suspect if the patient presents to you with the painless ulcers? Same site, pain. If the patient presents to you with the pain, you ask the history of pain, patient will tell there is no pain. So what are the things you are going to suspect?
Sir, if there is no pain, we can say there is loss of sensory involvement. Like, for example, if we say there is diabetes mellitus ulcer, then there is for like more than 10 years, patients who suffer from diabetic mellitus, they do not feel the sensory motor nerves. So they feel like they're walking on the sand because the sensory pain, touch, temperature, all these senses are lost. If there is motor involvement, you feel paralysis of intrinsic muscles. So all these things. It can also be case if we're going on a specific cause like leprosy. There is peripheral sensory are lost. The sensations for peripheral sensory are lost, and then there can be also if there are malignant ulcer, they are also painless.
Okay, you are right.
Bed sores, trophic ulcers. And then if there is any kind of spinal disorders, for example, sphingomyelin, tabes dorsalis, peripheral neuritis, or peripheral neuropathy, in all these things, we won't feel the pain in the ulcer.
Yes. So if a patient presents to you with the painless ulcer, we can commonly think of the peripheral neuritis as a sequel of diabetes mellitus, long-standing diabetes mellitus, because there will be peripheral neuritis. So the ulcer which develops from this is also called as neurogenic ulcer.
Yes, sir.
Tropic ulcers. In tropic ulcers, usually patient presents to you with the painless ulcer. If you ask the history of pain, patient will tell, no, I don't feel any pain. Okay.
Yes,
And
sir.
also due to other causes, tropic ulcers are due to other causes, as I told, like tabes dorsalis, transverse myelitis, and all. And usually the syphilitic ulcers, suppose the patient presents to you with the ulcer over the external genitalia, which is painless, we can also think of syphilitic ulcer. Okay.
Yes, sir.
Next,
Next slide.
what was the reason for asking about this negative histories? You asked for no history of fever, no history of claudication pain, and no history of altered sensation in the foot. So why did you ask
Yes,
those
sir.
questions?
So for history of fever, we take for the underlying conditions, like if there is any kind of infection, osteomyelitis, or is there any abscess formation, or any systemic infection, for example, in TB, syphilis. Then for diabetes mellitus only, if we take, there is necrotizing fasciculitis or sepsis is involved. And also for specific ulcers like leprosy or any kind of fungal infection. So all these things causes fever. So patient, if presents with the history of fever, we can rule out these diseases. Then for altered sensation, as I told, again sensory motor involvement in leprosy, syphilis, nervous disease like spinal cord injury or peripheral neuritis, peripheral neuropathy. In all these, in diabetes, neuropathic diabetes mellitus, you won't feel the patient won't feel the pain in the foot because there is demyelination of the neurons. And for claudication pain, so basically claudication is impaired blood flow due to peripheral arterial disease or any neurological disease. So we can rule out if the patient feels any pain in the calf muscles during walking due to low blood supply, we can rule out claudication pain. So all these three were not present in this patient.
Okay. So you asked the history of fever to rule out any constitutional symptoms secondary to infection. It could be
Yes, sir.
a ulcer,
Underlying causes.
meningitis. So in such cases, the patient also presents to you with the history of fever. So there is no history of fever, and there is no history of claudication pain. You asked history of claudication pain to rule out arterial insufficiency that might have led to the formation of an ulcer.
Yes.
Okay. If the patient gives a history of a claudication pain, then you have to grade the claudication pain according to Boyd's classification. Okay. And you asked history of altered sensation of the foot to rule out, as we have discussed earlier, this peripheral neuritis.
Atherosclerosis or any? Yes, sir.
Atherosclerosis comes in general both for claudication pain, addresses both atherosclerosis and Buerger's disease. Got it? So in general, the
Yes,
history of claudication pain is to address whether there is any arterial insufficiency that might have led to the formation of an ulcer.
Yes, sir.
Okay.
Yes,
This
sir.
much is basic
Sir,
about
do I have to tell the types also?
types of what?
Claudication pain like neurogenic, vascular, venous, or
If
musculoskeletal.
the patient gives history of claudication pain, then you have to grade it.
Okay, sir.
Okay.
Yes, sir.
If the
Next,
patient
sir.
is giving history of claudication pain, then it means some amount of arterial insufficiency might be there.
Yes, sir.
Okay. In elderly, we usually think of atherosclerosis, which affects the major and medium-sized arteries. In younger age, below the 40 years, we usually think of Buerger's disease, thromboangiitis obliterans. Got it?
Yes, sir.
Now, that is for clinical diagnosis. Okay.
Yes, sir.
Then past history, patient is a known case of diabetes mellitus since 5 years and is on regular medication. Patient, there is no history of previous such complaints, no history of hypertension, tuberculosis, asthma, epilepsy, and no history of previous hospitalization and surgeries. So this is to know for the comorbidities, because diabetes mellitus is one of the things which causes the formation of ulcer, and it is also a cause for non-healing of the ulcer.
Yes, sir.
Why did you ask for no history of previous such complaints?
So for repeated trauma, like if there is any previous ulcer that was present on the same site and the like foreign body is not removed, so there are chances of recurrent infections.
Did you ask for no history of history of hypertension, tuberculosis, asthma, and epilepsy?
Yes, sir.
You want to rule out hypertensive ulcers, tubercular ulcers?
Yes, sir. And
Asthma and epilepsy, they are not directly related to the formation of an ulcer, but it is better to know about the comorbidities of the patient.
yes, sir.
Why did you ask for
Sir-
previous hospitalization and surgeries?
Sir, to rule out like if there is any other surgery involved which can lead to
No, that won't be important. No
because
need for-
diabetes ulcers heal very slowly or they are generally non-healing. So if there is any kind of hospitalization or there is any mark of incision, they may lead to another ulcer. So there are chances of multiple ulcers on a patient of diabetes mellitus.
No, it is not important. It is not directly relevant to our case. Okay.
Okay, sir.
Continue.
Then personal
The
history.
diet is mixed up. Sleep is normal, bowel and bladder are regular and normal, appetite is good, and there are no addictive habits.
Yes, sir.
In personal history, you want to know about is smoking. Smoking history, whether a patient is a known smoker, and if he is a known smoker, since how many years he is smoking, and how many BDs or cigarettes he smokes per day, to quantify the cigarette smoking in pack years. Okay, that is important for our case.
Yes, sir.
Next. Drug
Then
history
drug
is on
history.
medication, regular
Diabetes.
medication for diabetes mellitus. Okay.
Yes.
Family
Then
history.
family history there is not significant. None of the members had previously any diabetes mellitus.
ಸ್ಟ್ಯಾಂಡರ್ಡ್ ಇಲ್ಲೇ ಕೊಡು.
So from this clinical history, you know that the ulcer started with the trivial trauma, maybe with a bleb. The patient doesn't know how the bleb started. The next day, it burst open to form an ulcer. And since 20
Yes,
days,
sir.
in spite of healing, it has progressed from 2 by 2 centimeters to 5 by 5 centimeters. And it was associated with
Yes.
pain, and also it was associated with whole smelling purulent discharge. The patient also complains of pain, and there is history of swelling of limb which started in the foot and spread towards the knee, involving both foot and the knee. From all these things, we can think like this could be an infected ulcer with or without cellulitis. Then this is what we think so far. Now we'll confirm all these things by the physical examination.
Yes, sir.
Continue.
Okay. So due consent was taken. An elderly 65 years old female patient who was moderately built and nourished, conscious, cooperative, and well oriented to time, place, and person. Her weight was 75 kg, height 155 centimeter, and BMI comes out to be 31 kg per meter square. No pallor, icterus, clubbing, cyanosis, lymphadenopathy was present, but edema was present, which was grade 3 till the knees. Temperature was afebrile. Vitals, pulse rate was 80 beats per minute, which was regular rhythm, normal volume, and no radiofemoral delay. BP was 126/80 mmHg, and respiratory rate comes out to be 16 cycles per minute. Local examination. Patient was examined under adequate light and exposed till knees with due consent was taken. Inspection. An irregular ulcer, a solitary irregular ulcer on medial aspect of the right foot, extending up to plantar, measuring 5 into 6 centimeter, measuring about 5 into 6 centimeter. Floor is covered with pale granulomatous tissue and slough.
Continue.
Purulent foul-smelling discharge is noted. Ulcer has sloping edges. Margin is edematous and inflamed. Surrounding area is inflamed and hyperpigmented. Edema is present till the knees of the right limb. Now, palpation.
Wait, Miss May.
No local rise. Yes, sir.
Go to the previous slide. The patient was examined under adequate light and exposed till knees. Okay. Inspection, a solitary irregular ulcer on medial aspect of the right foot, extending up to plantar, extending to the plantar surface. Okay. Not extending up to, extending to the plantar surface, measuring about 5 by 6 centimeters. A solitary ulcer means a single ulcer. Okay.
Yes,
Can you name some ulcers which are multiple in them? Usually to present with on inspection, there are multiple ulcers. Can you name some ulcers?
Sir, tuberculosis ulcer, then
Okay.
syphilis ulcer, and even malignancy. Some malignant ulcers can also be multiple in number.
Usually, tuberculous ulcer, it's okay, they can present in multiple numbers. The other is gummatous ulcer and venous ulcer. Usually, malignant ulcers are,
Difficult.
what is the other thing? Malignant ulcers, usually they are solitary. Usually, okay.
Okay.
So, generally, the multiple presentation, multiple ulcers are the common site, usually seen in tubercular ulcer, gummatous ulcer, and you may also see in venous ulcer. Okay. And there are typical sites for this ulcer. Where you commonly find tuberculous ulcer?
So in the neck, in the axilla and groin, we see tuberculosis ulcer. Diabetic ulcers are usually seen in the foot, upper arm, back, and then the perineum. Then coming on to the genital ulcers is seen on the external genitalia.
Syphilitic,
Then,
meant to say syphilitic ulcer. Okay.
yes, sir.
Syphilitic ulcer, rheumatism, differential ulcer, all these things. Okay. So we
Yes,
call
sir.
it
For the lips,
ulcer and heart
vulva.
Hmm.
Yes, sir.
all those things.
Yes, sir.
And the position of the ulcer where it presents is also important. Usually this venous ulcer, they are situated typically above the medial malleoli.
Yes,
Okay.
sir.
Usually this, what's a basal cell carcinoma? These are few typical sites. Basal cell carcinoma usually found in the line joining the angle of mouth to the
Angle
line
of
the
mouth,
ear.
the line here. Yes, sir.
Okay, that is why it is also called as
Ulcer.
teardrop ulcer.
Sir. Okay.
Okay.
Ulcer. Yes, sir.
Audible. Okay.
Yes, sir.
So
Yes,
these
sir.
are few ulcers which are typical in position. So these are venous ulcer and this rodent ulcer, tuberculous ulcer are found in places where there are tubercular lymphadenoma, usually in the neck, usually in the axilla or in the groin. Okay.
Yes.
So here it is a solitary ulcer. It's a single ulcer which is irregular in shape, which is situated in the medial aspect of the right foot, extending to the plantar surface and is measuring approximately about 5 by 6 centimeter.
Yes, sir.
The floor is covered with pale granulation tissue and slough. The floor means that is the visible part of the ulcer, what you see. And it
Yes,
is
sir.
covered with pale granulation tissue and slough. What do you mean by slough?
Sir, it is the dead necrotic tissue that is present over the ulcer.
It is situated in the floor. The dead necrotic tissue that is situated in the floor of the ulcer. The floor of the ulcer means the visible part of the ulcer is called as floor of the ulcer. We'll come again. What do you mean? There is a difference between floor and the base. I'll tell you. The floor means that is the visible part of the ulcer.
Visible part. Yes, sir.
Next is you can see purulent, foul smelling discharge is noted. Okay. What are the different types of discharges you know, and where you usually find it?
So, for example, if there is blood in the discharge, we see those in the malignant ulcer. If there is yellowish
Not for-
color, yellowish creamish color.
Okay, it's not for
Yes,
example.
sir.
Okay, it is purulent discharge usually seen in infected ulcers. Serous discharge is usually seen
Yes, sir.
in healing ulcers. Serosanguinous discharge are usually seen in tubercular ulcer and also malignant ulcers. And sanguine, usually blood is discharge. Soon after removing the dressing, the ulcer bleeds profusely. So it is a pathognomic of malignant ulcers. Okay. So you need to know about the types of discharges also.
Yes, sir.
The ulcer has sloping edges. What are the different type of edges you know?
Sir, so there are 5 types of edges. First one is the sloping edges, which generally is seen in the healing ulcer. It has 3 components. that is white, blue, and red component. The white one is due to the scar and fibrosis that is present. The blue one has the growing epithelium, and the red one signifies the red granulomatous tissue, granuloma.
Not granulomatous, it is
and
granulation tissue.
Granulation, sorry, sir.
Granulomatous is totally different. It is granulation tissue.
Yes, sir.
Please correct it. It is not granulomatous. Granulomatous signifies tuberculosis of chronic ulcers. Then
Yes,
we'll be
yes,
telling
sir.
now caseating granuloma,
Granulation.
presenting granuloma. That is a different terminology. We need to mention here
Yes, sir, yes.
granulation tissue.
Yes,
Okay.
sir.
It's not granulomatous. It is granulation.
Yes, sir. Granulation tissue.
Granulation tissue.
Then, yes, sir. Then averted is generally seen in the squamous cell carcinoma. Then undermined edge, characteristic of tuberculous ulcer,
Yes.
because it goes deeper in. Yes, sir.
Yes. Continue.
Then it goes. Yes, sir. TB ulcers, because it goes deeper into the plain subcutaneous tissue and the skin proliferates inwards. Then raised and beaded edge is seen in like pearly white appearance in the basal cell carcinoma, as we discussed, rodent ulcer, eardrop ulcer, because proliferating active cells is present on the outside and necrotic tissue is seen on the center. Then the fifth one is punched out. Punched out edge doesn't generally, these ulcers are limited and do not spread to the surrounding tissue. For example, arterious ulcer, syphilis, gummatous ulcer, and trophic ulcers.
Hmm.
So there are 5 types of the edges.
Okay. The surrounding area is
Then
inflamed
margin
and
is,
hyperpigmented, and edema is present till the knees of the right.
yes, sir.
Thank you.
The next
Next
slide.
slide.
Palpation. No local rise of temperature. Tenderness around the ulcer and in foot is present. Inspectory findings are confirmed and the ulcer size is 5.5 into 6 centimeter. The depth of ulcer is 0.5 centimeter and the base is made of subcutaneous tissue. The ulcer is mobile. Ulcer doesn't bleed on touch and there is no marked induration on the edges or the base or the surrounding areas. No loss of sensation in other parts of the right limb, and all the joints movement are normal.
Okay. So the first and foremost thing in palpation is you have to check for the local rise of temperature and whether the ulcer is tender to touch or not. Yeah.
Yes,
This
sir.
will tell about the ongoing inflammation and whether the ulcer is acute ulcer or not.
Yes, sir.
So that is why you have mentioned about there is no local rise of temperature and the ulcer is tender to touch. And there is also tenderness in the foot. And you have confirmed all the inspectory findings like exact dimension of the ulcers, its extent, where it is extending, where is the superior border, where is the inferior border, where is the medial and lateral border. That will tell the exact situation of the ulcer. Those are the things you are telling, like inspectory findings are confirmed. And the depth of the ulcer is about 5 mm, 0.5 centimeters.
Yes, sir.
You need to know about the difference between the edge and the margin. What is the difference between
Yes,
edge
sir.
and the margin?
Sir, basically margin is the transition area between the normal epithelium and the ulcer, whereas the edge is the area that is present between the floor and the margin.
Edge is the
So there are
area
two different
between the floor of the
floor
ulcer and the margin.
margin.
The area. Okay. So margin is the junction between the edge and the surrounding epithelium. Okay. Normal epithelium. Right. That is the difference between. These are the stock questions usually we'll ask. So what is the
Yes,
difference
sir.
between floor and the base? What are the types of edges you know and where it is typically found? What is the difference between edge and the margin? Yeah, these are usually the stock questions we'll ask. So here
Yes,
you
sir.
know about the edge now. Edge is the, sometimes we'll also ask you to write and show what is edge and what is margin and what is floor and what is base. Okay.
Yes, sir.
You can refer DAS for that. It is clearly mentioned. So edge is the area between the floor and the margin. Margin is the junction between the edge and the normal epithelium. Okay. And you mentioned ulcer is mobile.
Yes.
Ulcer doesn't bleed on touch and there is no induration. The base is made up of subcutaneous tissue. How did you palpate for the base?
So we pinch the ulcer margin and then we check for if there is any granulation tissue is present, how hard, if it's present on any bony surface, and if it's mobile in nature.
Usually, as your ulcer is small, 5 by 5 centimeters, you can
Yes, sir.
hold it with the thumb and the index finger and try to lift it up. Okay,
So we
from
pinch
this-
the. Yes, sir.
or lift it up. So from this, you'll know the underlying what's the base is made up of. Okay.
Yes, sir.
So what is the
Grade
difference
one.
between the floor and the base?
So floor is the area on which
Visible
the
part
base
of-
sets. Right, opposite, sorry. Floor is present above the base, so the visible part of the ulcer is called as floor, and the area on which it rests is the base.
The floor is the visible part of the ulcer. The things on which the ulcer rests on is called as base. Here, in this case, the base is made up of subcutaneous tissue. Okay. So I meant to say this is a superficial ulcer.
Yes, sir, grade one.
Okay, and you also try to move the ulcer in both the direction, and you told the ulcer is mobile, which means to say it is not fixed to the underlying structure. And the next
Yes,
is ulcer doesn't bleeds on touch, doesn't bleeds easily on touch. And the last is there is no induration. What do you mean by induration?
Sir, like for chronic long-standing ulcers or malignant ulcer, there is specific type of hardness that is associated with it. So if there, we see any hardness, we'll rule out if there is any malignancy or chronicity. It also is like relation is inversely proportional to the aggressiveness of the ulcer. If there is more induration, there will be less aggressiveness of the ulcer.
Now here, induration means hardness.
Yes, sir.
If you feel for induration, it could be due to two reasons. One is due to malignancy also. The other thing is also due to chronicity. So in malignant also there will be induration. The induration will be due to tumor infiltration. And in chronicity, it is due to excessive fibrosis. So induration doesn't mean always there is malignancy. So induration can also be present in chronic ulcers. So edges may be indurated, margins may be indurated, and base may be indurated. So induration simply means it is hardness. If there is hardness in the edge or margin or the base, usually it could be due to two reasons that you have to clinically correlate. It could be due to chronicity also, means chronic ulcers, callus ulcer. And the other thing is due to malignancy also. Induration due to malignancy is due to tumor infiltration. Induration in chronic ulcers is due to fibrosis. Got it? There is no loss of sensation in other parts of the right lower limb, and all joint movements are normal. Why do you want to check for sensation in other parts of the lower limb?
So to rule out the sensory nerve involvement. So like if there is again chronic diabetes mellitus case, for example, more than 10 years, they lose the sensory nerve involvement due to demyelination, and again motor and autonomous. There is, for example, in diabetes, there is diabetic neuropathy, due to which all these sensations won't be felt. So checking on all the other part of the right lower limb, because the arch swelling also extends till the knees, to check even till the knees there is any kind of sensation present or not.
How did you check for the loss of sensation?
Sir, we did sensory nerve examination, proprioception, fine touch, crude touch, all these
Pain
physiological examination.
and pressure. Okay. So all the joint movements are normal. Next.
Yes, sir. Examination of lymph node, no enlarged lymph nodes. Examination of nerve lesions, no suggestive sign. Examination for vascular insufficiency, no signs for vascular insufficiency.
Why did you do examination of the lymph node?
So lymph node will be enlarged in some specific type of ulcer. For example, if it's a tuberculous ulcer, there would be enlarged lymph nodes, stony, matted form lymph nodes. Also, since we are telling that there is a lot of, there is discharge, there are more chances of enlarged lymph nodes that can be present. Draining of lymph node would be a lot. And
Yeah, continue.
yes, sir.
So examination of lymph node is important because the examination of the ulcer is not
Also
complete
for
without
ruling
the
out any
examination of
malignancy.
the lymph nodes. Usually, if there is lymphadenopathy, the type of lymphadenitis or lymphadenopathy also suggests the diagnosis. Suppose in case of inflamed ulcers, we call it as reactive lymphadenitis. Usually, what will be the features of the lymph node? It will be enlarged and it will be tender. Later, it may lead to separated lymphadenitis and abscess formation. In case
Yes,
of
sir.
tuberculous ulcer, so the lymph nodes will be enlarged, matted, and then there might be slight tenderness. Whereas in malignant ulcers, usually the lymph nodes will be enlarged, stony hard, non-tender,
Yes.
and maybe fixed. Then, depending on the type of lymphadenitis, also we can come to a diagnosis. It also helps in the diagnosis. Like in reactive lymphadenitis, it will be enlarged and tender, and it will be mobile. In tuberculosis ulcer, it will be enlarged and matted. You know what is the meaning of matted?
Yes, sir.
They're clumped together. And there may be slight tenderness, whereas in malignancy, the lymph nodes are enlarged and they are stony hard, and they may be non-tender and they may be fixed.
Yes, sir.
Examine, there is no sign suggestive of any nerve lesions. What do you mean by examination of?
Yes, sir.
Examination for vascular insufficiency. So here you want to check for any presence of varicose veins and if there is any arterial insufficiency. Then,
Yes, sir.
in
rule out
examination of vascular insufficiency, there are no visible dilated and tortuous veins in the lower limb. And there are no things suggestive of varicose veins around the ulcers also. Okay.
Yes, sir.
And did you check for arterial insufficiency?
Sir, for example, I told claudication pain is seen in the articular, in the claudication pain, there would be a type of intermittent claudication, and to rule out for the atherosclerosis, Buerger's disease or Raynaud's disease, there is cramping type of pain we can ask, like if you feel any type of cramping pain. And there is also one thing that we would ask the patient to lie down and avert the leg above his heart level. So the patient feels a lot of pain if it's like that. So we can rule out if there is any kind of arterial insufficiency. And yes, sir.
Here, examination for vascular arterial insufficiency means we'll palpate for the peripheral pulses. Okay. This is
Yes, sir. Peripheral pulses, dorsalis pedis.
Where you check for, you should
Yes, sir.
the landmark. Where you check for the dorsalis pedis artery?
Sir, dorsalis pedis artery is one of the most palpable one. It is present between the tendons of extensor hallucis longus and extensor digitorum longus. Then for posterior tibial artery is also one of the example of peripheral pulses. So it is about 2 centimeters from the calcaneum and behind the medial malleolus in front of tendocalcaneum. Yes, sir. And in anterior tibial artery, we check above the ankle joint between tibialis anterior and extensor digitorum longus. And along with these three pulses, we do also check for popliteal pulse and femoral pulse. Femoral pulse is seen 4 centimeter below the mid-inguinal point in the femoral triangle, and popliteal pulse is checked in the flexion position of the knee to relax the popliteal fossa first, and with the use of 2 index finger, we'll put pressure on that and check for the popliteal pulse, although it's very hard to check for the popliteal pulse.
Okay. So you need to know the exact landmarks of all the peripheral pulses, because suppose there is an involvement of a small and medium sized arteries like below popliteal, antitibial, posterior and dorsalis pedis artery, and there is normal pulsation in the femoral artery. It means that there is a arterial insufficiency of the due to blockage, insufficiency in the medium and small sized arteries. Usually in medium and small sized arteries are affected in Berger's disease. And if the
Yes, sir.
large arteries also affected, you might think of atherosclerosis, because atherosclerosis affects large and medium sized arteries, whereas Berger's disease in TMO, it affects medium and small sized arteries. Based on these things also, we can come to a diagnosis if there is arterial insufficiency. Got it? So examination of the vascular insufficiency means both arterial and venous. In venous, you look for the presence or absence of the varicose veins. In arterial insufficiency, you will check for the arterial pulsation. Depending on the arterial pulsations, you say whether medium and small sized arteries are involved or large and medium sized arteries are involved. Got it?
Yes, sir.
That is the importance of knowing. We are doing examination for vascular insufficiency. Okay, continue.
Yes, sir. Then systemic examination, S1, S2 heard, no murmurs. RS bilateral, normal vesicular bed sounds are heard. CNS, no focal neural deficits. Per abdomen examination, no tenderness or organomegaly, and all quadrants move equally with respiration. Then examination summary. An irregular solitary ulcer measuring 5.5 into 6 centimeter is seen, and depth 0.5 centimeter is seen on the medial aspect of the right foot, that is extending up to the plantar surface. Ulcer has sloping, inflamed edges. Floor is covered in granulation tissue and slough is present. Foul smelling, scanty purulent discharge is present, and base is made up of subcutaneous tissue.
So if the examiner asks you to summarize the case, then you need to tell this thing like elderly female aged about 65. That is how you summarize the case. The elderly female aged about 65 years, she presented with the ulcer, which was gradually progressive with the purulent foul smelling discharge and pain in the lower limb. And patient is a known diabetic since 5 years on regular medication. On examination, the floor is covered with granulation tissue and slough, and there is also purulent discharge. And it is a superficial ulcer. So this is a summary. So total summary of the case. Got it? You need to mention only positive points. So next is diagnosis.
So differential diagnosis, a non-healing, non-specific, chronic diabetes ulcer on the right foot, and provisional diagnosis is a non-healing ulcer on the medial aspect of the right foot with diabetes mellitus.
Usually you can give a provisional diagnosis, clinical diagnosis itself. So clinical diagnosis would be non-healing ulcer of the right foot with diabetes mellitus. Okay. That is the clinical diagnosis.
Okay, sir.
Clinically, it is classified into healing ulcer, non-healing ulcer, or spreading ulcer, and third is callus ulcer. Yeah. Here the clinical diagnosis would be a non-healing ulcer of the right foot with diabetes mellitus. That is the clinical diagnosis of the ulcer.
Yes, sir.
So you should not mention diabetic foot ulcer. So that is the clinical diagnosis.
Yes, sir. That would be pathological. Okay. Yes, sir.
So differential diagnosis, why did you give differential diagnosis?
Sir, to rule out other possibilities that can be because of the ulcer. For example, non-specific, I told, because as per the pathological classification, we have specific, non-specific, and malignant. In specific, we tell because it is caused due to a specific organisms. For example, leprosy caused by Mycobacterium leprae, tuberculosis caused by Mycobacterium M. tuberculosis. Then we have actinomyces caused by actinomycosis bacteria. So all these comes under the specific one. Then we have malignant, basal cell carcinoma, melanoma, and squamous cell carcinoma. And then comes the non-specific. Here comes all the hypertension, arterial, vascular, then diabetes. All these comes under the non-specific one. I told about a non-healing one because it had scanty purulent discharge, which was false smelling, and slough was present. Generally, when we say about healing, there is very limited or no slough is present. So since the slough was present, it was main thing that diverted me towards the non-healingness of the ulcer. Chronic, because if the, as per the duration classification, if it's less than 2 weeks, we say it's an acute. And since the patient complained of ulcer for more than 20 days, I ruled out for chronic ulcer. And diabetes, because the patient was suffering from diabetes and there was no other vascular insufficiency. So yeah, a non-healing, non-specific chronic diabetes ulcer on the right foot.
Here we're not thinking about the differential diagnosis because clinically we are not thinking of tuberculous ulcer. As you told, we are not thinking of the malignant ulcer. We are not thinking of the specific ulcer. Why? Because on examination there is no induration. The ulcer doesn't bleed on touch, and it's only the history
Yes,
of
sir,
20 days. Yeah. So no
Yes.
need to do differential diagnosis. So it could be a non-specific ulcer, as you told. Non-specific ulcer, generally it's a diabetic ulcer because there is a clear history of patient with a known case of diabetes mellitus, and there is a clear history of
Yes,
ulcer
sir.
since
Right.
20 days. So you can, if you want to give a differential diagnosis, you can give it as a non-specific ulcer. Then that can be differential. It
Yes,
can be
sir.
provisional diagnosis. So here diagnosis should be non-healing ulcer of the right foot with diabetes mellitus. Yeah.
Yes,
Differential diagnosis is when you are thinking two or more types of ulcers. Is it not?
Yes, sir.
Pathologically, you classify ulcers as specific ulcers. They are called a specific ulcer because they are caused by specific organisms. Non-specific ulcers under this, it could be traumatic ulcer. Traumatic ulcer may be due to chemical, maybe mechanical or physical ulcer. Next thing is diabetic ulcer, arterial ulcers, venous ulcers, all those things. And malignant ulcers are squamous cell carcinoma, basal cell carcinoma, Marjolin ulcer, and malignant melanoma. You're not thinking of malignant ulcers here. You're not thinking of specific ulcers here. Is it not?
Yes, sir.
Continue.
Yes, sir. And then the management and inspection and all.
How do you want to manage this case?
So first of all, we have to see for the investigations finding that we can do for this case. So we'll do differential routine blood checkup, CBC, ESR, then checking for the amount of albumin that is present, hemoglobin. Then since the patient has diabetes, we would go for the RBS random blood sugar, postprandial blood sugar, and fasting blood sugar. Urine examination is not needed here, first of all, because we'll check from the blood examinations only. And then bacteriological examination, we'll do cultural sensitivity testing to rule out if it's caused due to any infection or bacterial invasion. So that we can treat it from the antibiotics. And then X-ray we would do for bony lesions or ruling out osteomyelitis if the ulcer has these deeper layers causing osteomyelitis.
Okay, we're not going much deeper
So
into
these
it
are the
because of the time
investigations.
constraints. Okay, in management, starting with the routine investigation, you'll get a hemoglobin estimation, you'll get a blood sugars, you'll get a total count, differential count, and ESR to know the disease progression. And you want to do bacteriological examination of the discharge, means culture and sensitivity test to know the offending organism and to check for the types of antibodies, it is sensitive. Then if you
And
want
we'll also do edge biopsy.
edge biopsy to rule out malignancy,
Malignancy
And-
and histopathological
Hmm.
studies.
X-ray of the foot here, in your case, X-ray of the foot to rule out bony pathology because it is situated over the bone, at the base of the
Yes,
great
sir.
toe, is it not?
Yes, sir.
So in that, in X-ray, the features suggestive of osteomyelitis are any periosteal reaction, any cortical irregularity. In X-ray, we think of osteomyelitis. Or else, if the underlying bone is normal, the osteomyelitis is ruled out. And the next is treatment part. So in treatment part,
Yes,
as
sir.
your case is a non-healing ulcer, you want to convert this into a healing ulcer. You put a broad spectrum antibiotics until the culture and sensitivity report arrive. Then, because there is a slough,
Yes,
you need to do debridement. So
Debridement.
debridement means you
Yes,
remove
sir.
all the dead and necrosed tissue so that smooth, pale granulation tissue is visible. And you
Yes,
do
sir.
alternate regular dressings. Depending on the discharge, you do regular dressings, you put antibiotics, and then the ulcer becomes healing. Then what you do?
Skin grafting we'll do proceed with the split thickness skin grafting. So in that a thin skin layer is harvested from the donor and is transplanted to cover the wound in order to increase the healing process. So it also has a type like thin, intermediate, and the thick one. So we'll do here the split skin grafting instead of the full thickness skin grafting.
As the ulcer is small, it is 5 by 5 centimeters. No? So when it
Yes, sir.
starts to heal, this wound gets contracted also. So there may not be a need for skin grafting. Ultimately, the ulcer may heal completely with little scarring. If the ulcer is large, then we can plan for skin grafting. Here, the best thing is split thickness grafting because split
Yes,
thickness
sir.
grafting has got more advantages. If the large area has to be covered, we will go for split thickness grafting. If we want a better cosmetic outcome, we'll go for a full thickness grafting.
Full thickness.
Ah.
Yes, sir.
The other name for split thickness grafting is Harris graft. The other name for full thickness graft is also called as Wool's graft. Okay. You need to know about the pros and cons of the split thickness or partial thickness grafting and full thickness grafting. And as your ulcer is
Yes.
small, it is 5 by 5 centimeters. Once it starts to heal,
It
it
can heal.
ultimately heal with a minimal scarring. So there may not be need for a skin graft. Okay.
Yes, sir.
This is all the basic
Yes.
thing you need to know. What the questions we have discussed is the stock question. Usually it will be asked. And the ulcer is a definitive case for an undergraduate practical examination. One ulcer case and one swelling case will be there as a short cases. Will be given usually 20 minutes for the history taking and examination and for the discussion. Got it?
Yes, sir. Yes, sir.
Any doubts?
No, sir.
I think we'll finish this because of the time constraints. It's more than 1 hour.
Okay, sir.
Do you have any doubts, Ms. Vedika?
No, sir. Thank you so much, sir.
No. Subrata ma'am?
Shall I stop the
Uh-huh.
screen sharing?
Yeah,
Yes.
you can stop.
Sir is also here, President, Honorable President. Sir,
Pawan, nicely you have covered the topic and explained the student how to examine, how to answer in the examinations. Or this type of questions. And usually these students will be having phobia during the examinations. So by conducting such this one webinars, the students will also feel this one encouragement, as well as they also lose the phobia and this one. So our academic and medical subcommittee is doing very good this one. Projects they are coming out and beneficial to the all the students who have attended today. So thank you, Dr. Pawan, and also thanks to Dr. still see the student, Vedic Varun. Congratulations for the good presentation.
Sir,
so much, sir.
just a few words. I mean, Dr. Pawan sir has been not just like an examiner, he has been a guide, and
Yeah.
many places he has asked questions, he has answered how to answer. He
Yeah,
has
yeah,
very non-threateningly he has done this. And as a psychiatrist, I feel these kind of sessions are very much required for our students who have examination phobia, as rightly told by our IMA president, sir. Sir, thank you so much on behalf of IMA KSP Academic Committee. Do we have Aditi?
Yes, ma'am.
Yeah.
I would like to thank Vedika and Pawan sir for giving us such a beautiful session. It was really, really nice and informative. Now I would like to ask Tanushri to deliver the vote of thanks.
Good evening, respected dignitaries and fellow members of the MSN. I am Tanushri Kailash Nair, the co-convener of IMA MSN Karnataka. It gives me great joy to be able to deliver the vote of thanks after this very insightful clinical case presentation. It has been an enriching experience, and it is my honor to express our sincere thanks to all those who have contributed to making this event a grand success. First and foremost, I would like to extend a heartfelt thank you to Dr. Pawan sir for moderating this presentation. Your attention to detail and the excellent explanation for every point made this presentation an enriching learning experience for all of us. I would also like to thank Vedika Verma for presenting this case. You truly did a wonderful job, and we look forward to more such presentations in the future. I would like to express my gratitude to Dr. V.V. Chiniwala sir, Dr. Suriraju sir, Dr. Shubhrata ma'am, John sir, Gaurav Jaidev sir, Prasanna Kumar sir, and Aditi. Without their dedication, planning, and relentless efforts, none of this would have come to fruition. We are certain that everyone has walked away with something meaningful today. Also, a very big thank you to Dr. Palaksha sir and Dr. Geeta ma'am for taking the time out of their day to attend this session. To all the attendees, thank you for being here and showing your support. Your participation has made this event even more special, and we hope that you leave with new knowledge, perspectives, and connections. A big thank you to the organizing committee, volunteers, and everyone who worked behind the scenes. Once again, thank you to each and every one of you for being a part of this memorable occasion. We look forward to seeing you again at future events. Thank you.
Thank you, sir.
Thank
Sir,
you, ma'am.
mute ಆಗಿದೆ. Sir,
Thank you, sir. Thank you, Tanushri.
Chiniwala sir mute ಆಗಿದೆ.
ಹೌದು. Good night.
Good night, sir.
Thanks
Thank you,
to
Pawan
all.
sir. Thank you.
Okay.